Yeah, we can start.
Let them come. Everybody come. Yeah.
Please start.
Good evening, everyone. We cordially welcome everyone to ISA National PG online class. This class is held on every Monday at 6:30 p.m. Myself, Dr. Purnima Raut, secondary NB student from Bhaktivedanta Hospital, Mumbai. I will be one of the skin coordinator for today's session. And in today's session, we will discuss a case of mitral stenosis for mitral valve replacement. Mitral disease often necessitates mitral valve replacement. The anesthesia management of mitral valve involves careful pre-op assessment, hemodynamic control, smooth induction and maintenance, vigilant post-op monitoring, and close team collaboration. So today we are going to have a wonderful session on this. But before we commence, we'll start with the academic session. Let us invoke with the divine blessing of Lord Saraswati by beginning with the Saraswati Vandana. I may now request our Honorary Secretary of ISA Nationals, Dr. Sukhminder Bajwa sir, to address the audience. Sir, please.
Thank you, Dr. Purnima. Last week we had a class on the same topic, but for the non-cardiac surgery. Now, see, that's not a permanent solution. That patient may be landing up in surgery every time. So in mitral stenosis, we have to have some definite treatment also. The best option is the mitral valve replacement. So when you carry out these patients for mitral valve replacement, it's entirely a different domain with a cardiac anesthesiologist coming into the picture with so many of the complications, so many of the considerations you take during these surgeries. So I think this is a very apt series where we started with the cardiac things and going on to have step-by-step approach how to deal with these patients. So I think it's a very important class today and how you really manage these patients because tomorrow, whenever the patients come with the post mitral valve repair also, how you deal with that. So this is also another important issue. So I think we have got a very good team. Dr. Thomas Koshi will be there and now Dr. Sarana Babu, both are well known in the field of cardiac anesthesia. So they will be dwelling upon with their PG students whom they prepared very well for this class. So Purnima, you can take it from here.
Thank you, sir. Now I invite my co-screen coordinator, Dr. Pratyasha Nayak, to introduce our faculty moderators and also to outline the session formats and rules. Over to you, Dr. Pratyasha.
Thank you, Dr. Purnima. A very good evening to all. Myself, Dr. Pratyasha, Assistant Professor from IMS in Some Hospital, Bhubaneswar. First of all, I welcome all our distinguished faculties for today's session. So to begin with, our first respected faculty, Dr. Thomas Kosi, sir, who is currently working as Professor Senior Grade in Cardiovascular Anesthesia in Sri Chitra, in Trivandrum. Well, he needs no introduction. Sir is an eminent academician with remarkable achievements in the field of cardiac anesthesia. He completed his MD and DA from Medical College, Kottayam, Mahatma Gandhi University, Kerala. PGCC in cardiac and neuroanesthesia from Sri Chitra Institute, Trivandrum, and followed by FRCP. He has been awarded with many fellowships and honorary posts during his 35 years of anesthesia practice. Sir has 98 publications, that with all from index journals. I welcome you, sir, for today's session. Our second respected faculty, Dr. Sarvanan, sir, who is currently working as additional professor in cardiothoracic and vascular anesthesia in Sri Chitra Institute. With his 12 years of PG training experience, Sir holds special interest in cardiovascular anesthesia, perioperative echo, opioid sparing cardiac anesthesia, and regional nerve blocks. Apart from his innumerable fellowships to adorn with, Sir was the university topper in MD anesthesia, and he has 78 publications and index journal to add on to his achievements. I welcome you, sir. Respected teachers, I kindly request you to introduce the students during the session. Before that, as we proceed towards the session, I would like to enumerate few rules of the class. First of all the viewers will be muted throughout the class. And anybody who is having any kind of questions or doubt, they can write it in the chat box, which we shall continue during the discussion session. So I'd like to hand over the microphone to our teachers and the students, Dr. Abhinay and Dr. Satish, so that we can start the class. So please.
Yeah. So good evening, everyone. Thanks for the introduction, and I thank the ISA team for inviting our institute to this PG class. So today's topic is on mitral stenosis patient coming for a mitral valve replacement. So Dr. Bajwa, like Bajwa sir told, last class is on mitral stenosis patients who have been posted for a non-cardiac surgery. So the ultimate cure for these patients is to undergo complete treatment, whether with a mitral valve replacement or a mitral valve repair. So whatever it is like. So today in our class, we'll be dealing more on the cardiac surgical aspects, the anesthesia for those cardiac surgeries. So it will not be like regular class for like a cardiac patient for a non-cardiac surgery. So we have prepared the class in such in a scenario like if a patient with severe mitral stenosis with symptoms coming for a treatment. So how we have to provide anesthesia for those patients to undergo a cardiac surgery, what are the options available, and what are the intraoperative goals and intraoperative cardiopulmonary bypass management, as well as on the postoperative care for those subset of patients. So with this short introduction, I would like to introduce our postgraduates who are the pillars of our working force in our department. So today we are going to have the presentation with Dr. Satish, who is a third-year senior resident doing DM in cardiothoracic and vascular anesthesia, and Dr. Abhinaya, who is a batchmate of Dr. Satish, and both of them are in the final years, and they are about to give their exams in coming December. So we hope that they will do a good presentation, and the discussion will be very nice today. Thank you. Over the mic to Dr. Satish and Dr. Abhinaya.
Thank you, sir.
The presentation.
Good evening, everyone. Today we'll be presenting on a case of mitral stenosis for mitral valve replacement. I'm Dr. Abhinaya, and this is my classmate, Satish.
Coming to history, our patient is a 56-year-old female who is a homemaker by occupation from Trivandrum, coming with chief complaints of breathlessness on exertion for 3 years, and palpitation for 2 years, and fatigues for 6 months. History of presenting illness, patient was apparently normal 3 years back, and when she developed breathlessness, it's insidious in onset, progressive in nature, exceptional mild limitation in household activities is there. Breathlessness is relieved with rest. No history of breathlessness on lying down or waking up at night with breathlessness. It is not associated with cough or wheeze. You see, complaint palpitation since 2 years. It's insidious in onset, exertional, associated with breathlessness on exertion, not associated with chest pain or sweating. She also complains of increased fatigue in the past 6 months. No history of chest pain or pedal edema or syncopal episode. No history of cough, expectoration or hemoptysis. No history of difficulty in swallowing or change in voice. No history of weakness of limbs currently, and no history of claudication pain. Past history, the patient had a history of progressive dyspnea into 1995. That time she was diagnosed to be a valvular heart disease, for which she has undergone a procedure which involves incision in the left thorax. It probably closed mitral valvulotomy. She also gives a history of palpitations in the past, followed by breathlessness, which required multiple hospital admissions in the past and needed oxygen support. And in 2018, she had a history of right upper limb and lower limb weakness, diagnosed to be a left hemicerebral artery stroke, and she had undergone mechanical thrombectomy, followed which she was started on blood thinning medication. Currently, she had no neurological deficit and recovered after 2018. No history of fever, sore throat, or joint pain in the childhood. Not a known case of diabetic, hypertensive, TB, or ischemic heart disease. Personal history: patient had no history of addiction, no normal bowel and bladder habits. Family history: say is married with 2 children, normal vaginal delivery, no similar illness in the family. Obstetric and menstrual history: attained menarche at 14 years of age, regular cycles with normal flow. Treatment history: patient has been initially started on warfarin, and now currently she has been bridged with heparin. She is taking 5,000 units IV TDS, and she is taking penicillin 400 mg BD and metoprolol 50 mg BD, tablet digoxin 0.25 125 mg OD, and she is taking tablet arsamide 20 mg BD, tablet aldactone 25 mg OD, tablet panda 40 mg OD. Summary: our patient is a 56-year-old female with present with breathlessness on exertion, which is progressive in NIGA grade 2 for past 3 years. Palpitations on exertion present, and the easy fatigability is there for last 6 months.
Okay, Dr. Satish. Before going to the examination,
Yes.
so can we have a little discussion on the history of the patient as well as on the what are the current medications and what is going on? So, what is the clinical symptoms that the patient is currently having like?
So patient had a breathlessness on exertion for 3 years, sir, and
Okay.
palpitation there for 2 years, and fatigability for 6 months, sir.
Okay. So what it indicates, like what are the, I mean, like palpitations, dyspnea, and fatigue. So what are the?
Sir, it's not associated with cough or expectoration. It is mainly going towards the cardiac side, sir. So
Okay.
maybe patient is already having history of valvular heart disease in the past, and
Okay.
so it is due to the dyspnea due to the valvular heart disease, and
Okay.
dyspnea due to the maybe when species dying down or doing exertional activity, there may be increased preload to the heart. It might cause pulmonary edema. Breathlessness might be due to that. Palpitation might be due to the increased heart rate, which might be the atrial fibrillation is most common in this patient. Palpitation one is due to the atrial fibrillation, other might be due to the increased heart rate, which compensate for the reduced cardiac output in a fixed cardiac state like mitral stenosis. And ECG fatigability also can be explained with the low cardiac output because of stenotic mitral valve, if it is a mitral stenosis.
Okay. Also, there was a previous history of closed mitral valvotomy, which clearly shows that patient was having a mitral valve disease. And okay. So do you expect any of the symptoms in this subset of patients?
So they might be having a chest pain. It might be due to the right ventricular hypertrophy. If there is the pulmonary hypertension associated with it, there might be RVH, which will cause chest pain.
Okay.
The RV will get blood supply during systole and diastole. So due to the systemic pressure, pulmonary pressures are very high, there might be reduction in blood supply to right ventricle, which will not right ventricular infarct. There might be a chest pain might be there.
Okay.
And
then any other symptoms? One is chest pain, then?
Patient might have cough with
hemoptysis.
hemoptysis.
So what could be the reason for the cough with hemoptysis in this subset of patients?
Because of the pulmonary venous condition and pulmonary apoplexy, there will be thin dilated bronchial vessels, which might rupture leading to hemoptysis because of increased airway pressure and back pressure changes.
Okay, so any other symptoms? Any
Because of
difficulty?
the
Yeah.
because of
Difficulty.
dilated left atrium, that could be difficulty in swallowing because it compresses the esophagus. There could be recurrent laryngeal nerve compression, and there could be change in voice.
Force supplies mainly there.
Yeah, because the deccanal laryngeal goes into the tracheoesophageal groove, which is behind the left atrium. Sometimes it may get stretched, and that may cause a recurrent laryngeal nerve palsy and hoarseness of voice. Okay, so one more history the patient has, like the patient has had a history of cerebrovascular accident in 2008. So what could be the reason you think of like this? It could be because did you expect this because of atherosclerotic narrowing of the cerebral vessels, or due to some other
It
reason?
may be embolic stroke because the patient is having mitral cirrhosis from the past, sir. So she might have anticoagulants might not be adequate, so might get a atrial fibrillation with the LA clot that might get embolized. That might be the reason.
Okay, now she has recovered completely, right? So
Yeah, sir.
that CVA incident was 7 years before.
Yeah, 2018, sir.
Okay, so currently, so what are the patient is having any obstetric history?
Sir,
What
to
was-
normal vaginal delivery, sir. Uneventful.
That was when, like now now she is 54 years.
The
So
vaginal deliveries were more than 25 years back.
2020.
Before she was
Okay.
diagnosed to have valvular disease, before the CMV, she had to go
So before the CMV, she had 2 kids.
Yes.
Okay, so it was unevenful.
Yes, sir.
It was not detected at that time by having
Yeah.
a valvular heart disease.
Yes.
Okay, okay. So what are the medications she is on right now?
She's currently on injection heparin.
Sure.
Warfarin she was taking, sir. That was bridged with heparin. Now she is taking heparin 5000 units IV TDS, sir.
Okay,
And she's taking penicillin 400 mg BD and
okay,
metoprolol 50 mg BD. Digoxin 0.125 mg body. And
okay.
tablet Tarsamate 20 mg BD, sir. And Allerton 25 mg body.
So what are these medications are being used for, do you think, like?
Warfarin has been used
These
for
medications are
anticoagulants.
started, like, so one is
Warfarin
a
has-
beta blocker, one is an anticoagulant, and other is a anti-failure medication,
Yes.
and other two were diuretics.
Yes.
So can you please, yeah,
So the patient would have been started with warfarin. She was diagnosed to have AF with embolic stroke, and it was bridged to heparin before surgery. 5 days back, warfarin was stopped and bridged to heparin. For
okay,
rate control for AF, metoprolol has been started, and digoxin can help in increasing inotropy also and to decrease the rate AF, and diuretics for the heart failure management.
okay. So the patient is in failure now, and patient is having a rhythm issue also, apart from the valvular heart disease. These are the additional issues in this patient. Okay, so what is next? So history-wise, you had a, conclusion that patient is having a mitral valvular disease and heart failure medications, as well as atrial fibrillation.
Nice.
Okay,
Coming to examination, on general examination, patient was conscious and oriented, moderately built and nourished, weighing 61 kgs and a height of 148 centimeters with a BSA of 1.58 meter square. There was no pallor, icterus, stenosis, clubbing, lymphadenopathy, or pedal edema. She had a pulse rate of 72 beats per minute, irregular, low volume. All peripheral pulses were present. No radial or radiofemoral delay. Vessel wall seems apparently normal, and apex pulse deficit of around 10. NIBP measured in the right upper limb and supine position measured 118 by 64 mmHg, and respiratory rate of 14, regular, thoracoabdominal with no use of axillary muscles. So saturating 100% on room air, afebrile, and JVP was not elevated. Airway examination showed adequate mouth opening with more than 3 finger breaths, modified Mallampati grade of 2, no restriction in neck movements, and Allen's test also. Both the radial and Allen arteries appeared patent in both the hands. On cardiovascular examination, inspection, precordium seemed normal except for the surgical scar in the left hemithorax and submammary region, the CMV scar, and the apical impulse could not be visualized. On palpation, apex beat was felt at 5th intercostal space, 1 centimeter median to the midclavicular line, tapping in character and irregular. We could not feel any thrills, parasternal heave, or palpable P2 was not there. On auscultation, S1 has to be present with loud S1, There was a soft blowing, low-pitched rough rumbling, mid-diastolic murmur of grade 3 intensity at the mitral area, and there was a loud P2 at the pulmonary area. No other click or rub could be heard. On respiratory examination, there was normal vesicular breath zones in bilateral lung fields, and no adventitious sounds like repetitions of bronchi were present. Abdominal examination was normal, with it being soft and tender, and no organomegaly was seen. CNS examination revealed normal higher mental functions and no focal neurological deficits. Provisional diagnosis. It's a case of mitral stenosis, probably of rheumatic origin, currently on NIHA grade 2, with atrial fibrillation and controlled ventricular rate, with pulmonary hypertension, not in heart failure, with history of thromboembolic complication in the past, and a history of previous cardiac surgery, CMV.
So, okay. So, from the physical examination as well as the systemic examination, so what are the positive findings you got?
Sir, she is in AF with pulse rate. She is in AF with irregular pulse, and there was apex pulse deficit of around 10. But all peripheral pulses were palpable, so there is no embolic events to the all peripheral limbs. And otherwise, JVP was not. We could not see the elevated JVP, though the patient had a palpable P2. I mean, loud P2 could be indicator of pulmonary hypertension.
Okay.
And mid-diastolic murmur was there with loud S1, mitral stenosis.
Okay. Any parasternal heave was there?
No, sir. Parasternal heave was not there. Right ventricular hypertrophy, if it is there, parasternal heave might be present. We could not find any parasternal heaves.
Okay. So only loud P2 was there, which suggests pulmonary hypertension.
Pulmonary hypertension.
So pulmonary hypertension and palpable P2 was there.
Yes.
Okay. So what about the thrill? Any thrill you can able to feel in this patient on palpation?
Thrill we could not feel, sir. Only mid-diastolic murmur was there. Thrill we could not feel. Grade 3 murmur only.
It's a grade 3 murmur.
Yes, sir.
Okay. Okay. So any opening snap you can able to hear? So what is opening snap?
Opening snap occurs when the stenotic mitral valve opens. There is bellowing of the mitral valve during diastole. That can give an opening snap. Depending on the interval between openings S2 and opening snap, we know this. We can estimate the severity of mitral stenosis. As it becomes shorter, the interval becomes shorter. That is the severity of mitral stenosis is more.
Okay. Okay. So any other positive findings you got in this patient? Sorry, I cannot hear you, Satish. What are you saying?
Sir, apart from that, we didn't get any extra findings on examination.
Okay. Okay. So you made a provisional diagnosis. Then how to confirm this diagnosis? This is based on your clinical examination history. So what are the additional investigations? First of all, we have to confirm whether it's a mitral stenosis. Then only you can decide like what type of intervention the patient need. So,
Yes,
so what are the further investigations you want to do, like to confirm your diagnosis?
I want to do ECG, chest X-ray and 2D echo.
What are the things? Can you please tell me?
ECG.
Okay.
And 2D echo.
Okay.
Transthoracic echo and chest X-ray.
So these three investigations, because you made a diagnosis that the patient is having a disease of cardiac origin. There is a valvular heart disease. So you want to do an ECG, chest X-ray, and do a routine two-dimensional echocardiogram. Okay. Okay. So can you
angiogram also I want to do because patient is 56 years. I want to do angiogram also to rule any other coronary artery disease also.
So you are thinking that there could be a coronary artery disease also associated with this. So you want to do coronary angiography also. Okay. So what is the indication for coronary angiography in this patient? Because you are having a clear-cut diagnosis from the physical examination and the history. The patient is having a mitral stenosis. Why you want to do a coronary angiography?
Since the patient age is 56 years, that might be associated coronary disease also due to atherosclerosis. So patient is going for cardiac surgery, she can undergo CABG if any additional grafting is needed. So possible if it is ready, then we can do.
Okay, so the current guideline, what the current guideline says, patients more than 50 years, patient has to undergo a coronary angiogram if the patient is undergoing any other cardiac surgery.
Yes.
So that is the current recommended guidelines. So according to that, you want to do a coronary angiography for this patient along with other investigations. Correct, no?
Yes.
Yeah, okay. So shall we proceed with
Yes,
the
sir.
invest? Okay, yeah.
Coming to investigations, first we will do a basic investigation, hemogram, renal function test, and we'll do liver function test and coagulation profiles. Patient is planning to go for a major cardiac surgery. I want to take all this investigation. After that, I want to do a
So
early ECG.
what was the coagulation profile in this patient?
Sir, PT is around 14, sir. INR is 1.12, sir.
Just show me. Yeah, INR is 1. Patient was on warfarin, no? How come?
Patient is warfarin, but has been bridged with heparin. So,
Okay. So
warfarin,
what was the APTT
INR
then?
might come down. We should have taken APTT also.
What was the APTT value now? Have you checked the APTT?
APTT value is around 80, sir. Now. Yeah, we
80.
checked. It's around 80, sir.
Okay, so the patient is bridged to heparin and
So it's the normal. So yeah.
okay. Okay, rest of that there is any so what is the importance
heparin,
of,
so slowly INR has come down.
okay, so liver function test you did. Why you want to do liver function test in this subset of patients?
And patient with RV dysfunction with the pulmonary hypertension, there might be a congestive hepatomegaly which will cause liver dysfunction.
Yeah, so that could be the reason you should
So
look
I want
for
to see
the
the
liver function test also. So there could be a congestive hepatomegaly which may cause deranged LFT values. So before subjecting the patient to cardiopulmonary bypass, so we should normalize the liver function if the liver function is deranged. Otherwise, the patient may go on for ischemic hepatitis and
Hepatitis.
postoperative liver. Okay.
Yes.
So the hemoglobin is okay in this patient?
So hemoglobin is 9.5, sir. So there may be dyspnea due to the anemia also. So I want to check baseline and it might be kept as a baseline for a cardiac surgery. Any further
Okay.
optimization is needed, I will do that.
Okay, renal function test, what you want to do?
The renal function test is the my metastasis is a fixed output state. There might be reduced renal supply, it might cause renal leak also. So
Okay.
the renal function test and serum electrolytes is taking diuretics. There might be a alteration in electrolytes. So I want to optimize the
Okay.
electrolyte before surgery.
Okay. Okay. So what the investigation says, like what is the overall picture you got from the investigations?
So the investigation looks almost everything is fine, sir. Hemogram.
Patient is not having either organ dysfunction apart from the heart, right?
Yeah,
Liver
yes.
function is okay, renal function is okay, hemogram is okay. So okay. Okay. Okay, then. So
Then I want to make a early ECG, sir.
okay, yeah. So what does this ECG says? Can you read the
No
ECG?
patient is no patient. Yeah, no patient is in AF, sir. With rate of around now with control heart rate with rate of around 60 with ventricular toughness 60 and no, we are not able to see any bifid P waves or any right ventricular hypertrophy here. So there is no pulmonary hypertension here.
Okay, the patient is in atrial fibrillation, no?
Atrial fibrillation, yeah. With rate control, ventricular rate is control.
Yeah. Can you please show the atrial fibrillation? How you diagnose atrial fibrillation? What are the ECG findings of atrial fibrillation in this patient?
So RR intervals are irregular with P waves are absent, sir.
Okay, how the P waves are now? It looks fibrillatory, right?
Fibrillatory.
Yeah. Okay, then does this patient
Irregular RL.
so irregular heart rate is irregular. So rate is around how much?
Around 60.
60, sir. So we have to take full leads. Rhythm stick is around 10 seconds. So we have calculated the rhythm stick full R waves and then into 60
Okay.
around 60, 65 is the ventricular rate. Because of dejection and the other metabolic heart rate is controlled. The rhythm is not changed, but rate control.
Okay. So if it is a sinus rhythm, what findings could have been expected in this patient of severe mitral stenosis?
We could see a P mitral because of the enlarged left atrium.
Okay.
In lead 2, we'll have a bifid P wave. And V1, we can see a biphasic P wave.
Okay.
Pulmonary hypertension is the right ventricular hypertrophy is there. So R wave in V1 is more than 7 mm.
Okay, so that's suggestive of right
Prominent
ventricular.
7
And
V6.
Steven V6.
What is it?
Yeah, right ventricular hypertrophy is there.
Can you please talk close to the mic? So
When
that,
there is right ventricular hypertrophy.
yeah.
Whenever right ventricular hypertrophy is there, we will see R wave in V1 more than 7 mm, sir. And the S wave will be prominent in V6, sir.
Okay.
So it's not seen in this.
In this, so there is no right ventricular hypertrophy in this patient. So
Yeah.
what is the findings of pulmonary hypertension you can able to make out in ECG? But it may not be possible.
Right ventricular hypertrophy only. Right ventricular hypertrophy only can make out.
Yeah, so that is an indicative or indirect indicative of pulmonary hypertension is present.
Yes.
Okay. Okay. So any left ventricular hypertrophy is, will the patients have left ventricular hypertrophy in mitral stenosis?
So right ventricular hypertrophy mostly only present.
Why?
Stenosis occurs before the left ventricles. From the left atrium to left ventricle. Left ventricle mostly seen in the patient, AS patients, so hypertensive patient. And our afterward is more after the aortic valve, then only manifests as area.
Okay, so if you find a left ventricular ECG signs of left ventricular hypertrophy, then it always indicates them some other associated pathology after the LV. So mitral stenosis is before the LV, so it's not any left ventricular hypertrophy or LV dilatation or LV failure in these patients. Okay, so this ECG gives an idea that patient is having a atrial fibrillation, but it's not showing P mitral or anything with the issue of left atrial hypertrophy due to some other valvular pathology or something. Okay, so next investigation.
Yes.
So your physical examination of
Just
atrial
check
fibrillation is confirmed with the ECG, correct?
ECG.
Okay.
Yes,
So
yes.
next investigation is X-ray.
Next is chest X-ray, sir.
Yeah.
Chest X-ray. So we are able to see the right and left atrial borders. Might be due to the LA enlargement.
First tell me what is this X-ray? It's a AP or PA? Chest X-ray.
It's a PA view, sir.
PA.
Chest X-ray PA view, sir.
Okay.
Yeah.
Okay, then what are the findings you can able to see?
With straight and left heart border because of enlarged, probably because of enlarged left atrium.
Okay, what are
And
the
there is some mild cardiomegaly is there.
cardiomegaly?
Sorry,
Okay. Okay, cardiomegaly, then?
Some mild cardiomegaly is there.
Okay.
Then straight and left heart border and prominent
Bronchoscopy mounting, sir.
Okay. So what is the reason for the straightening of the left? What forms the left heart border of the heart? Or what are the structures which
it's
form
formed by
the left
the
heart border?
aortic knuckle, pulmonary.
Yeah.
It's formed by the aortic knuckle, pulmonary vein,
And then left atrium.
Okay.
But because of the enlarged left atrium and pulmonary hypertension, there will be straightening of the left heart border. And
So what it is
also
called?
because of the LA enlargement, there could be mitralization.
Mitralization of the heart.
Yeah, this is a classical feature of mitralization due to mitral stenosis. Okay. Then, so will these patients develop cardiomegaly? You told that left heart will not be going for dilatation or hypertrophy. So what was this reason for this cardiomegaly?
It could be because of the RV
Yeah, also.
Yeah, it is because of RV hypertrophy.
which we could not positively see. Yes, sir.
Yeah. So how will you determine the cardiomegaly? What is
Though we
this?
could not positively see it in ECG.
Your voice is breaking. Hello?
Sorry, sir. How would it?
Yeah.
Hello, yes, sir.
So how will you determine
So we can see the. So we measure the cardiothoracic ratio. We have to see the distance of the right and left heart borders from the midline, maximum distance, and divided by the total thoracic.
How do you do? Can you show it here with the
If it is more than 0.5,
Can you show with the pointer how to measure the left heart border, right border,
Pointer.
and
Yes.
the
so we'll be measuring.
which is the left heart border, which is right heart border?
So from the midline.
Okay.
From the midline, we have to go to the left heart border. This considering this is A, and then we'll measure the right heart border from the midline.
Okay.
And we have to add these and divide it by the total transfer.
Okay, so that gives you a idea of CT ratio and whether the patient, how much to say that the patient is having cardiomyopathy, the CT ratio of how much?
More than 0.5.
50%.
Yeah, more than 0.5 is considered to be a cardiomegaly. So what other findings you can see apart from the heart? In the lungs, any findings?
So there is antler sign. There is yes, so there is increased pulmonary markings. The hilar region is very prominent with pulmonary vessels. There is cephalization of the pulmonary.
And when sometimes playing of carina will be seen because of LA, now it's not seen in the patients. And sometimes double density strain will be seen in the right heart border because of LA enlargements. LA and RA will be seen separately. That is also not seen here.
Okay.
And with pulmonary mass evidence, some curly B lines, horizontal B lines will be seen here in the middle and lower lobe of the heart.
Okay.
Due to pulmonary edema changes.
Okay. Then any other findings?
It's an anesthetic X-ray, we'll see this.
Okay. So the chest X-ray gives an idea of there's some RV hypertrophy is there, and the metallization of the heart is there, and increased pulmonary vascular marking, which is suggestive of pulmonary hypertension and increased pulmonary vascular pressures. So
Yes, sir.
okay, so you are telling about the pulmonary hypertension. So what class is the pulmonary hypertension?
Pulmonary.
It's a post-capillary pulmonary hypertension due to the increased LA pressure.
Okay, so what class it comes? There are 5 classes of pulmonary hypertension, no?
Yes, sir.
So what class it?
Pre-capillary, post-capillary will come in class 4.
Class 4 or class 2?
Not sure. Post-capillary will come in class.
Patients with left heart disease it comes under class 2, no?
Class 2, okay.
Class 1 is class 2 is patient with left heart disease having a pulmonary hypertension because of that. So it's a class 2 pulmonary hypertension. So it's a post-capillary pulmonary hypertension class 2. Okay. Okay.
Okay.
Okay. Okay. Then next investigation, what do you want to do? So ECG and X-ray.
Next, I want to do the
Okay. Transthoracic echo. Okay.
I want to do a transthoracic echo.
Okay.
Yes, sir. Now it's a apical 4-chamber view. It's showing a LA-LV, RA and RV. Sir. Here I'm able to see a stenotic mitral valve, thickened valve, and restricted opening is there. Here in the color flow Doppler, we are seeing flow turbulence is there in the left side with the thickened mitral valve is there. Sir.
Okay.
And
So one second.
here,
Can you show the one second?
Yes,
Can
sir.
you oops.
Yeah.
So the left hand side, what is the findings like apart from the thickened and fused calcified mitral valve?
Yes, sir.
So what are the other findings?
Left atrium enlargement is seen.
Slowly you can show in the pointer so that everybody can
There is
follow us. Yeah.
there is an enlarged left atrium.
Okay.
Stenotic mitral valve and the thickened fused chordae also.
Okay. And what about the LV and RV and RA? How is the
RV is
RV?
comparatively dilated.
Okay. RV is dilated.
Dilated.
RV is dilated, sir.
Okay.
Usually RV should be 2/3 of LV. Now it looks like almost similar size of RV and LV, and also its size is higher than the LV. So it's RV dilation is there.
Okay.
So RV dilate also there.
Yeah, mild RA dilatation is also there. Okay, so the next one is the color Doppler imaging, right? So we are going to put a color Doppler across the mitral valve, and we have to assess the flow across the mitral valve. So what it shows like?
Yes, sir.
What is the finding?
turbulence across the mitral valve.
How you say that the flow turbulence?
Flow turbulence.
Can you pause the video? Is it possible for you? Yeah, that's the one. Okay. Yeah. So that is a flow turbulence. When during diastole, when the blood flows from pillar to LV, there is some flow turbulence is there. Okay.
So mitral valve opens.
Yeah.
Yes, sir.
Okay. So any other images you have like? So you just see with the 2D examination and the color Doppler examination, which shows a mitral, some turbulence across the mitral valve, but you are not knowing how much is the turbulence. So for that, what you will do to know that how is the gradient, how is the pressure gradient? Yeah.
Yes, sir. So next we have to see the gradients. For that, we have to put a continuous wave Doppler. Pulse wave Doppler will work only pressure of velocity of less than 1.5 meters. So this is might be stenotic mitral valve. We have to go with the continuous wave Doppler. We'll align it along the flow. So we'll put a continuous wave Doppler and waveform is showing this. After that, we'll trace this VTA, which will give a velocity maximum gradient and mean gradient.
Okay.
So here velocity is around 3 meters per second. Maximum gradient is 36 and mean gradient is 20, sir.
Okay. So since the velocities are higher, the continuous, what are the types of Doppler? Pulse wave Doppler and continuous wave Doppler, right?
Pulse Doppler and continuous wave Doppler.
Okay. Pulse wave Doppler is to measure low velocities, and continuous wave Doppler is to
Yeah.
measure higher velocities more than 1.5 meter per second. So here the velocity is very high, correct? So here velocity is 2.9 centimeter per second.
Yes, sir.
Can you show that?
Yes, sir. Yes, sir.
Yeah, yeah, it's 2.9 centimeters. So you have to use a continuous wave Doppler, which measures the higher velocities. So the velocity is between the left atrium and left ventricle. So you are going to see
Yes,
the
sir.
pressure gradient between left atrium and left ventricle,
Yes, sir.
right? So the continuous wave Doppler given a velocity
Left
of
ventricle.
2.9. Okay, so
Yes, sir.
so how to get that mean and the peak gradient? After this waveform will come. This is the flow waveform. So how you will measure the gradients?
Yes, sir.
You will trace, no?
You will trace the VTA. So based on that, after that, machine will automatically give a maximum gradient and mean gradient, sir. The pre-assumed calculations.
What is the maximum gradient and mean gradient here in our patient?
Maximum gradient.
Maximum gradient 36, sir, and mean gradient is 20, sir.
Okay, so what is the normal gradient expected in patients with mitral stenosis? I mean,
So
the
less
grading
than
of
5 to 10, more than 10, sir.
Okay, so that is mean gradient or
Normal patient should be less than 5, sir.
normal patient is less than 5.
Mean gradient.
Okay.
Mean
So
gradient.
mild mitral stenosis?
Less than 5, and moderate 5 to 10, and more than 10 is severe.
Okay. Okay. So then what is the next slide? You showed something. What is that? What you are trying to calculate in this?
So it's like a pressure. Pressure of time, sir. It's actually the time taken for the pressure gradient to become half. That's the pressure of time.
So time
So
gradient.
this pressure of time will give an indirect estimate of one. So a pressure gradient between LA and LA to become half. Pressure gradient to become half, sir.
Okay, so the gradient is between the left atrium and left ventricle across the mitral valve. So that gradient, how much time it takes to reduce to half that gradient. So that is called pressure of time, right?
Yeah. Yes, sir.
Yes.
So okay. So
Yes, sir.
what it indicates?
So it will indirectly give an idea of a stenosis mitral valve, sir. It's valve area is calculated by 225 pressure of time.
That indicates the severity
of mitral disease, sir.
Okay, what is the normal value? Or I mean,
Yes,
how much?
Sir, more than 220 is mild MS, 150 to 220 is moderate, and opposite. Less than 150 is normal, 150 to 220 is moderate, more than 220 is severe MS. Okay,
the more the pressure of time, less the severity of mitral valve disease. Correct, no? Because the time takes more. Time takes less.
No, more the
more the pressure of time, more the pressure of time, more severe is
the MS, sir.
Yeah.
Because 225 pressure of time.
Yeah.
Valve area will come down, sir.
Yeah, so 220 by pressure of time. So if the pressure of time is more than 220, then the valve area
will come less than 1.
Less than 1. So that is the pressure of time.
Less than 1.
Okay. So more time taken for the pressure to come down, it means that the more the severe disease.
More severe.
Yeah. So in our patient, how was the pressure of time?
So pressure of time is around 225 millisecond with a value area of around 0.98 centimeters square.
Okay. So valve area is less than 1. What is the normal valve area, mitral valve area?
Normal mitral valve area is around 4 to 6 centimeters square.
Okay. So here the valve area is less than 1. So as your findings
Yes,
and history and examination, so as conveyed that patient is having a severe mitral stenosis, and from the echocardiography, which is one of the gold standard investigation for the evaluating the mitral valve disease, first line of investigation, which also shows CV patient is having severe.
severe
Okay.
MS.
Okay. Okay. Next. So you confirm the atrial fibrillation with ECG and X-ray. You find the patient is having pulmonary hypertension and signs of right ventricular hypertrophy, and echo also gives same findings. So what is this?
So now we have focused mainly on right side of heart. RARV is dilated. So we have put a color flow Doppler on the right side.
Okay.
So it's showing a tears. Tricuspid reagitation is there.
Okay. So where it is?
It's between tricuspid happening. We are put a color flow Doppler towards the right side of heart. So we are seeing a tricuspid reagitation over here. Sir.
Okay. During systole, the flow is coming from RV to RA, right?
Yes, sir.
Okay. So where you are
same continuous wave Doppler we have aligned. After that, we have taken a TRZ we have taken, sir, and maximum velocity we have measured.
So what is this?
Sir, we have measured to see the severity of PA. Sir. We have to see a continuous wave Doppler we have to align towards the TRZ and take a maximum velocity. It's like 4.86 centimeters square. Sir. By modified Bernoulli's principle, it will give a indirectly give a pressure gain of 9.94. It's if pulmonary valve is normal, it will be considered as RV pressure. 94 plus RA means the RV pressure. So the patient is having severe PAH according to this.
So it is an indicative of severity of pulmonary hypertension. TRZ, because of the back pressure changes, the pulmonary artery, so the RV will be ejecting the blood into the RA instead of into PA. So it will give an indirect estimation of pulmonary artery hypertension. Correct?
Yes.
No? That's the thing you want to say.
Yes.
Okay. In this patient, how much it is? So 94.
94 plus RA pressure also we have to take. Then it will be around.
So RA pressure, if it is around some 13, 14, it will be more than 100, no?
Yeah, severe PA.
So what is the normal PA pressures like? How much it will be in a normal patient having a blood pressure of 120, 80?
So less than 35 is normal. Sir.
Okay, so
35 to
if it
50
is more than 50, then it is?
50 to 70 is more than 70 is severe PA. Sir.
Okay, so what is more indicative, whether you should take a systolic pressure or the mean pulmonary artery pressure to diagnose a pulmonary hypertension?
So according to guidelines, it's like mean pulmonary artery pressure of more than 20 is pulmonary hypertension.
Okay, so systolic pressure more than, but definitely it will be more than 25. So this patient is also having a severe pulmonary hypertension. Back pressure changes are there, which is showing a severe TR and also severe pulmonary hypertension. Okay.
Yes.
Okay, next.
Next is a parasternal long axis. It's showing LALV and aorta. Here we are able to appreciate the same stenotic mitral valve.
Okay.
And here probable LA clot might be there. Sir. Like one mobile structure is there in both the LA. That might be LA clot.
Sure, but are you sure that's a clot?
So that might be artifact also. It's like doubtful.
Okay, so what is the best this thing to investigation to show the LA clot?
We have to do a transesophageal echocardiogram.
Transesophageal echo better.
Okay, so why it is more this thing? More
because mitral valve is a posterior structure, it will be seen properly assessed by TE, but to TT.
Okay, so LA is a posterior structure. So if you do a thoracic echo, is an anterior structure. I mean, we are doing the echo from the anterior chest wall, which is a far field. The LA will be in the far field. So it will accurately pick up the clot. Some artifacts and all may come. We may not sure. Okay, it looks like some mobile mass in the LA, but it could be artifact also because aorta is coming and RVOT and RA and all will coming in the view. There may be some artifact also may be there. Okay.
Yes.
Okay, next.
Similar parasternal long axis with color dot. After that, next we have freeze to take an LA measurement. Like
Okay.
here, LA has been measured in a parasternal long axis view, 50 mm is there, sir.
Okay.
LA is
What is the
dilated.
normal? What is the normal LA size?
It should be less than 30, sir. 30.
Okay. So to say dilatation, how much it should be more than?
42.
50, sir. More than 50 is dilated.
More than 40 is
40 is
considered.
40.
dilated.
Okay. So on the right hand side, one image, what it shows like?
Here we have taken M mode to see the ejection fraction based on the T. Cooley's formula, sir.
Okay.
But most reliable is a modified Simpson method, but we have tried with even the parasternal long axis to estimate the ejection fraction. The LV function dysfunction we have seen, we should have gone with the modified Simpson, but contractility looks normal, so we have taken with
Okay. So LV is grossly eyeballing. It seems to be normal only.
so we
Yes.
take with
There is no LV dysfunction or anything.
Yes.
Okay. Okay. Next.
next is the parasternal stalk axis view. It's
Okay.
focusing mainly LV and RV. Here we are able to see the mitral valve with the commissures also fused and thickened valve is there, so stenotic valve.
Okay.
And we have freeze and taken planimetry areas.
Okay.
In a diastole, it's around full open valve, it's around 0.567 centimeters square, it's around 0.6 centimeters. Pressure of time showed around 1 centimeter, here it's showing very less, 0.6. So,
Okay.
curative MS.
Which is more reliable, whether to calculate the mitral valve area by pressure of time or directly tracing the, you directly trace the mitral valve opening, no? In this image,
Yes, sir. Yes, sir.
it's more reliable, this one or pressure of time?
So pressure of time is actually in patient with AF, it won't be reliable. And patient with some AR is there will be a difference will come. So planimetry, if we properly take image, it might be comparatively better compared to pressure of time.
Okay, so in both these things, the mitral valve area is less than 1. So both show the severe mitral valve disease. So coming to the valve, as you're showing in the left side picture, what could be the etiology for this mitral valve disease? What do you think like?
So here is a commissure fusion in there.
What is commission?
Here, anterior and posterior commissures fusion is there. Maybe a problem of rheumatic etiology.
Okay, so then what else? How the valve looks like?
The fixment appearance of narrowed opening in there.
This is the fish mouth. Can you show that properly? Yeah, this is the fish mouth opening of the mitral valve, and valve is thickened,
Thickened and rolled.
and it starts from the
Tips.
tip of the leaflets.
Yes.
Tip of the leaflet is more thickened than the annulus.
Yes, sir.
Fissures are fused. So most likely this shows a rheumatic.
Rheumatic attack.
So what are the other causes for mitral stenosis?
Sir, in elderly patients, it could be because of degenerative calcific MS. In that case, the calcification will start from the annulus and go towards the tip, and there won't be any commissural involved.
Okay.
And congenital causes, congenital MS is there.
Okay.
That will manifest in early childhood and
Yeah, so congenital MS, rheumatic MS, and degenerative MS. And what are the other causes for mitral inflow obstruction apart from this valvular pathology?
Because if there is an LA myxoma or a ball valve thrombus, those can obstruct the mitral inflow.
Okay, so in our echocardiography images, there is no such findings. So
Yes,
we are having this, and also the coming from also from the history, we can able to see that the patient is having a kind of rheumatic origin of the mitral valve disease.
Yes.
So, and also our echocardiographic examination is also pointing towards the same.
Yes, sir.
Okay. Okay. So then what is the plan? Summarizing the echo report. Yeah, just summarize it so that. Yeah, what is the diagnosis?
So LV dimensions are normal with the LVEF of 67%. LA is enlarged with 50 mm diameter. And there is a severe TR with severe PAH. Mild RARV dilatation is there with the mitral valve area of 0.9 by PHD method and 0.6 by planimetry. And the mitral valve is calcific and thickened. I'm going to diagnose a severe rheumatic severe mitral stenosis with mild MR and a LA clot, probable LA clot with good LVRV function and a severe PAH.
Okay. So this is our echo report. So the
Yes, sir.
patient has come for corrective surgery, so corrective treatment plan. So whether this patient, what are the treatment options available? Okay, any other investigations you have done before going?
Coronary angiogram.
Yeah, you told that coronary angiogram is needed because this patient is age more than 50, which is one of
50.
the guideline recommendation to do a coronary angiography, right?
Yes.
Yes.
Yes, sir.
Okay, so what is the finding in coronary angiography?
Here vessel looks normal in caliber with no atheroma thrombus either.
Okay,
So no associated coronary artery disease either.
so no coronary artery disease. So this patient needs any additional intervention apart from intervention of the mitral valve?
Mitral valve, and sometimes we need to address the tricuspidal. We have to assess an intraoperative PE, and we have to decide whether to address tricuspidal or not because severe TR is there.
Okay. So what is the next? Yeah. What is the next plan of management? What is the treatment options available to save this patient?
Sir. Sir, should we go with the questions?
Yes.
Go with the quiz question, we'll go with the discussion.
I think we can finish these quiz questions and go for the discussion next.
Okay, sir. So there are 5 questions initially. So you can answer in the chat box and our screen coordinators will note it. First question is, which of the following clinical findings is more specific for mitral stenosis? A, loud P2. B, mid-diastolic murmur with presystolic accentuation of the apex. Basal crepitations in the lungs. And D, elevated jugular venous pressure.
Shall we go with the answer?
Yeah, screen coordinators, please coordinate. I think
Yes.
the
Most of the people have answered B, that is the mid-diastolic murmur with pre-systolic accentuation at the apex.
Yeah, that will be the correct answer.
That will be the correct answer. Answer is mid-diastolic murmur with presystolic accentuation of the apex. In our patient, we didn't have a presystolic accentuation because patient was in AF, and this is because of the atrial contraction at the end of the diastole. And this is very characteristic and specific for MS, caused by the turbulent flow across the mitral valve. Loud P2, it is an indication of pulmonary hypertension, but it's not specific for MS. And the basal crepitations can occur in any the case of left heart failure, and elevated GVP will seen in any case of right heart failure. Coming to the second question, which is the most common cause of mitral stenosis worldwide? A, rheumatic heart disease. B, congenital mitral anomaly. C, senile calcification. And D, infective endocarditis. Shall we go to the answer?
Majority have answered rheumatic heart disease, option A.
Yes, ma'am. The answer is rheumatic heart disease. More than 95% of MS cases are because of rheumatic heart disease only, following rheumatic carditis. Degenerative calcification causing MS is very rare and occurs in elderly people. Question number 3. In a patient with severe MS, the most important determinant of symptoms are A, left ventricular systolic function, B, heart rate, C, SVR, system of resistance, and D, coronary artery perfusion.
Yes, they have gone with heart rate as the answer, option B.
Yes, ma'am. That's correct. And in the case of mitral stenosis, with the increasing tachycardia, there will be a decrease in diastolic filling time, on which the cardiac output is highly dependent. So because of this increased tachycardia, diastolic filling time decreases, left atrial pressure increases, leading to the symptoms. LV function is usually preserved until very late, and SVR and coronary perfusion have minimal effect on the symptoms. Question number 4. The interval between A2 and opening snap is inversely proportional to A, LA pressure, B, LV compliance, C, RA pressure, and D, SVR.
Yes. So majority have opted for left atrial pressure, option
Yes.
A.
Yes, ma'am. And that's correct. And so, as we have discussed, shorter the A2 and opening snap interval, higher is the LA pressure, and more severe is the MS. Coming to question number 5, the most common complication of untreated mitral stenosis is A. Infective endocarditis, B. Atrial fibrillation, C. Stroke due to embolism, and D. Pulmonary edema.
So everybody has opted for atrial fibrillation as the answer.
Yes, ma'am. Atrial fibrillation, it occurs in 40 to 50% of patients due to LA dilatation. Embolism and pulmonary hypertension are secondary issues following LA dilatation.
That's all my question.
Okay. So most of us are following us. So
According to this, we are conventionally we are classifying the mitral stenosis into mild, moderate, severe based on the pressure gradient of 5 to 10, more than 10. But now after 2022, 28 guidelines, they have described as at risk, progressive, asymptomatic, severe, and symptomatic severe MS.
okay. So now the gradient, grading the severity of MS based on the
Gradient is not taken.
mitral pressure gradients, as you told, rate of more than 5 to 10, all those things has become
Taken
taken
out
out,
from the.
the guidelines. And so how they are classifying the severity of mitral stenosis now?
So now they are taking as a 4 stages, stage A, B, C, D. Sir.
Okay.
A is at risk for MS, B is progressive, and C is asymptomatic severe, and D is symptomatic severe MS. It's
Okay.
like only wall area will be taken into consideration. It's like more than 1.5 centimeter square is like in the at risk and progressive. In severe MS will be less than 1.5 centimeter square area, and the
Okay.
pressure of time will be taken here less than 150, and here more than 150 in the severe MS.
Okay.
So apart from that, valve anatomy will be taken into consideration.
Okay.
And symptoms will be taken as symptomatic severe MS when there is no symptom. So we have consulted.
Yeah, tell us.
So we have consulted the guidelines. Like as we discussed, mostly the valve area will be taken into at risk and progressive. Asymptomatic severe and symptomatic severe less than 1.5 centimeters square valve area.
Okay.
Asymptomatic stage also they are further classified into C1, C2. C1 is like pulmonary artery pressure less than 50 systolic pressure, and pulmonary systolic pressure is more than 50. It's like asymptomatic severe with the pulmonary hypertension.
Okay.
So according to recent guideline, these two group need intervention, C2 and D. A, B, C, we can wait for intervention. So they have classified accordingly. So here this approximately all patients more than 5 to 10 only will be given for asymptomatic C1, C2 and D. So now we are not considering this valve gradient for the severity. So our group needs intervention is C2 and D. Our patient will come in a category of D, symptomatic severe MS with valve area less than 1.5. Symptom is there and pulmonary hypertension also there.
Okay. So our patient is having. So what are the findings according to this in our patient? Can you go back?
Yes, sir. Our patients are having a mitral area less than 1.5 centimeter square.
Okay.
And symptomatic, sir. Grade 2 NIGA, grade 2 dyspnea is there.
Fatigue and palpitations are there.
Yeah, yes.
Patient is
dyspnea.
symptomatic, dyspnea.
Palpitations and EC fatigability.
EC fatigability is there.
Okay.
And pulmonary hypertension also there based on the echo findings.
The echo findings, and patient is having a loud P2.
Yes, sir.
Yes.
And palpable P2 is there. Okay. And mean gradient is more than 22.
Yes,
Yes,
more
sir.
than 20.
20.
Okay.
So we are not considering it's very high gradient, sir. That will become a severe MS.
Okay.
Symptomatic severe MS.
So our patient falls under the category of symptomatic severe MS.
Yes.
So
Yes,
what
sir.
interventions you want to do in this patient? What are the interventions available for this patient to treat?
Sir, percutaneous balloon mitral commissurotomy is there, and surgical valve replacement is there, sir.
Okay.
And open commissurotomy is there, but in a patient with a mitral stenosis, rheumatic etiology, mostly will go for a BMBC and if valve is playable and suitable. Otherwise, we have to go for a mitral surgery with replacement. Repair also will not be possible in a rheumatic heart disease. Most of the time, the degenerative disease only will be. Stenotic mitral valve repair is not possible. So mostly two options only will have.
Okay, so our patient can able, I mean, whether our patient can undergo a balloon mitral valvotomy?
No.
Sir, actually, patient is having a probable LA clot is that we have to evaluate with DE. And
Okay.
otherwise, valve is also, we have to assess the Wilkins score to see the valve.
What is that Wilkins score? How to evaluate?
So the Wilkins score is a echocardiography criteria, sir, to assess the valve suitability for percutaneous balloon mitral commissurectomy. It's
Okay.
taken with the 4 parameters: lead mobility, thickening, calcification, and subvalvular thickening.
So what is the
So-
subvalvular thickening? What it indicate? What are the structures? The
So we have to see the chordae, sir. Subvalvular structures like thickening of chordae.
So what's chordae?
So we'll see the papillary muscles also. So starting a papillary muscle, thickening of chordae.
Chordae is
That-
what? What is chordae?
Chordae is the structure which connects the mitral valve to the LV, which is also an apparatus of the mitral apparatus, part of the mitral apparatus. Through the papillary muscles and chordae, mitral valve leaflets are connected to the LVs.
Okay. So when the mitral
These also-
valve, when the mitral valve, so the chordaes are string-like structures which connect the papillary muscles. That is a
With
part
the
of
mitral.
LV to the mitral valve leaflets. So
Yes.
it will help with the opening of the mitral valve and closing of the mitral valve.
Yes,
When
sir.
mitral valve is disease like rheumatic, disease may extend into the chordae also.
Chordae.
Chordae.
Yes.
The subvalvular apparatus that is called chordae and the papillary muscles have been affected by the rheumatic pathology, and they also goes for thickening, calcification,
Yes, sir.
and shortening. All those things may happen.
Yes, sir.
So that also should be taken into account while doing a balloon mitral valvotomy, whether the
Yes.
valve is amenable for balloon mitral valvotomy. So
Yes, sir.
the Wilkins score was devised. So how to grade that?
So
Which is
the-
planned for
sir, each one will be given a 4 score, sir. 1 to 4. 1 is the best score and 4 is the worst score. Leaflet mobility, thickening, calcification, and subvalvular, sir. Based on these parameters, score will be given to 1 to 4, sir.
Okay. So
Less than 8 is favorable for PMBC. More
Okay.
than 8 is not favorable for BMBC. Sir.
Okay, so these are the indications for a percutaneous mitral balloon
Mitral valve.
commissurectomy.
Yes, sir.
Yes.
So Wilkins score should be how much? It should be less than 8.
8.
Yes.
It means that everything should be less than 2.
Yeah, almost everything should be less than 2 in average.
All the 4 things: leaflet calcification, thickening, and mobility and subvalvular thickening. All these things should be less than 2.
Yes, sir.
Okay. Okay. So are the indications?
Yeah. And the LA clot should not be there. Commissural fusion is there in our patient, but valve is thick valve with the LA thrombus probably is there. But MR is not there in patient. 1+ is there. But patient won't be an ideal candidate for PMBC or patients.
Okay. So based on this evaluation, you say that our patient may go in for more risk if you go for a mitral balloon
Balloon
commissurectomy.
mitral comes. Yeah.
What will happen? Okay, you can subject this patient to a percutaneous procedure. So what
Yes,
are the
sir.
complications can happen?
So it could result in a severe MR,
Okay.
which that will be an acute MR, and our LV might not tolerate the MRs.
Why
And
MR
even if you
So if the valve is not very pliable and we try to do commissurectomy, it might give
Tear
off
off.
and that could be severe MR, acute severe MR.
Okay. So
even
this-
commissurectomy is possible after that thick valve is there, sir. So there won't be a reduction in MS also. Thanks.
okay. So if you do a balloon mitral commissurectomy, it is more harm than benefit, right?
Yes.
Yes,
Yes,
sir.
sir.
Okay. So what are the next option you have for this patient?
Patients will go for a mitral surgery with mitral replacement is better option.
So you're
It's
saying
considering-
mitral valve surgery with mitral valve, I mean, mitral valve replacement is a better option.
Yes, sir.
Yes.
Okay. Okay. So,
It's like
So-
indications for a
so this patient is so options were closed or open commissurectomy, but this patient already undergone CMV, right?
same.
Yes.
Sir.
Valvotomy. So what is that closed mitral valvotomy? What is that procedure?
So they will give an incision in the submammary region, or the left submammary region, and they will blindly do a commissurectomy without opening the LA or LV. And they
Okay.
will
So blind procedure is done in olden days. So nowadays it's almost absolutely not done in any site because there is more risk of MR and complications are more compared to other better options like now percutaneous. If valve is playable, we can go for a PMBC or we'll go with the mitral valve replacement. So this is not done in nowadays in many
Okay.
centers. So.
Okay. Okay. So open commissurotomy.
So,
Anatomy is favorable, then we can open the heart and do a commissurotomy. But better is to do a.
when so
mitral
going
valve.
for open heart surgery, the patient will be benefited with replacement for a long time. That won't be
Yeah. So
achieved
this,
in open.
yeah, this patient is also having involvement of the subvalvular apparatus. The valve is also not pliable. If you go for open commissurotomy also without replacing the valve, so it is not also going to benefit the patient.
Yes.
Yes,
So
sir.
better to replace the valve so that patient may not come for a re-stenosis or further complication. So the best treatment option we can provide for this patient is
Replacement.
okay. Okay. So
And
what other problem is patient apart from mitral stenosis, mitral valve replacement? What are the any other additional surgery you want to perform along with
TR.
So this patient has a moderate to severe TR and tricuspid repair also we can do, but for that we have to measure the tricuspid valve annulus. How big is the annulus? If it is dilated, then we can go for
Indexed more than 21 mm per meter square, indexed dilated is there, then we have to go for it. But even a patient going for a left heart surgery with the severe TR is there, it's interrupt T showing severe TR, we can go for replacement. Sir. Moderate TR is there, we can go with the annulus, indexed annulus. So
Okay.
patient might get from repair, TV repair also.
Our patient is having severe tricuspid regurgitation.
Yes. Yes. Sir.
Okay, so this patient may also need a tricuspid valve intervention also apart from mitral valve replacement to give a complete cure because
Yes, sir.
already mitral valve has been affected because of the mitral tricuspid valve has been affected and the RV has been affected because of the mitral stenosis.
Yes, sir.
The tricuspid valve is dilated. That is the thing, right?
Yes, sir.
That only
Functional
the
TR is there.
So why the tricuspid annulus is dilated?
So because the functional TR, because of RV dilatation. Sir.
Because of the back pressure changes.
It's not due to organic, it's due to the functional.
Okay. Okay. So what next then?
And this patient is having indications beyond symptoms. The patient is having a pulmonary hypertension and new atrial fibrillation is there. Even she is asymptomatic also, she will come in a category of surgery. The patient would not have been symptom also. She is having this atrial fibrillation and pulmonary hypertension. According to guidelines C2, we have to do so. Now patient came up with us to stage D.
Okay.
Yes, sir.
So these patients are asymptomatic severe patients, right?
Yes, yes, sir.
So what are the indications were symptomatic severe and for surgery?
And asymptomatic severe with pulmonary hypertension and new onset atrial fibrillation, pulmonary systolic pressure more than 50.
Symptomatic severe and asymptomatic severe with these three findings.
Yes, sir. Excess intolerance is there. Even then these three indications are there, then we have to go with the stage C2, we have to intervene.
Okay, okay.
It's like we find about the calcific MS.
Okay.
The calcific MS is increasingly seen in the elderly people with the leaflet or annular base calcification, and there won't be any commissural fusion. In these patients, commissurotomy or balloon mitral commissurotomy will not be effective. And but surgery is also technically difficult and high risk because of the annular calcification. The sutures might give off when we take sutures in a place of calcification. So the intervention is indicated only if symptoms are very severe and refractory to medical therapy.
And we can post this patient for ME or metal replacement.
Okay, so now we are going to do a mitral valve replacement surgery for this patient.
Yes.
Okay.
Yes.
So what are the preoperative preparation?
So preoperatively, I will assess the patient. I will do the drug optimization. Sir. The patient is an injecting heparin 5,000 units IV TDS. I want to stop 6 hours before surgery. And
Okay.
I want to continue the penicillin 400 mg and the metoprolol 50 mg I will continue, sir. And dejection also I will continue, sir, for rate control. Diuretics I will assess the patient is NIGA grade 2. There might be chance of pulmonary dyspnea also, so I will continue night dose of diuretics. Sir. And aldactone I will skip because there might be a electrolyte disturbances. And the Pantop, in addition to that, I will give a diazepam 5 mg in the night and morning. And for 40 mg Pantop for night and morning.
Okay, so whether you want to skip digoxin or you want to continue, whether it will have any effect if you skip or you had, because digoxin is having a 5 days schedule, right?
Yes, sir.
Yes.
Sir, even if we pulse, it will be level will be maintained same.
Okay, the plasma
But
level
for-
will be made. Skip
Yes,
toxin also.
But
Okay.
postoperative rate control we can continue, sir, but it will be better. The contract will improve and also rate control will be there. Postoperative patient should not go again to the AF with fast rate.
Okay. Okay, so what is your anesthetic goal? So you have examined everything patient. So previous, I mean, like airway is okay, and no other issues.
Mhm.
So what is your induction goal?
So
How will you
goals of induction would be to maintain a low normal heart rate, because a higher heart rate may increase the pressure gradient across the LA, and to maintain adequate preload because of the fixed obstruction, adequate preload will be required, and to maintain a normal sinus rhythm. But in our patient, there is an AF, so we have to maintain a controlled ventricular rate. And XPR should be maintained with adequate contractility, and we should avoid rises in PVR by avoiding hypoxia, hypercapnia, cirrhosis, and we have to give adequate enough anesthesia and analgesia. So once patient comes to OT, after attaching base standard monitors, we'll secure a whiteboard peripheral line, and under local anesthesia, we'll secure a radial arterial line. And then we'll induce with 1 to 2 mg of midazolam and 2 to 3 mics of
Per kg of fentanyl.
2 to 3 mics per kg of fentanyl, and a titrated dose of propofol or etomerate can be used for induction. And after assessing the ventilation, we can give vecuronium as a muscle relaxant and intubate. And after that, after same temperature probe, and we'll secure a triple lumen in the neck, right AGV triple lumen we can secure. And then
We have to do a TE
TE
assessment.
also we have to do. And since we have a suspicion for
LA.
LA clot, we can also place a NIRS monitor.
Okay, so monitoring wise, what are the monitorings you will take?
So heart rate, a 5-lead ECG,
Okay.
arterial line, CVP,
Arterial line, central
CVP,
pressure monitoring, okay,
and NIRS,
NIRS,
then temperatures.
temperature, depth of anesthesia,
Otherwise-
CO2,
Yes, sir. It is CO2, urine output.
depth of anesthesia monitoring, what you will use like.
We can use MAC. We can see we'll be giving an inhalation anesthesia. MAC.
If
Or if
entropy or
we
Bissell,
have this, we have.
Okay, BIS or entropy you can use.
Yes.
Okay. So will you put a pulmonary artery catheter? What is your, I mean, our institutional practice?
We usually don't pulmonary artery catheter unless patient is very sick, very poor LV or RV function. Unless it's there, we don't usually place a pulmonary artery catheter.
patient is an IGA grade 2, so mostly we won't put in our institution pulmonary catheter for this.
Also, this patient might require a tricuspid valve intervention. The pulmonary artery catheter might be interfering with the symptoms.
Okay, a patient is also having severe pulmonary hypertension sometimes. So during occlusion of the balloon and all may cause some rupture of the pulmonary blood vessels and may cause pulmonary hemorrhage. So
Yes,
it is always a little high risky to introduce a pulmonary artery catheter, float a pulmonary artery catheter in these patients.
Yes.
Okay. So you have been induced a patient. So what other any for analgesia, any regional nerve blocks you will try?
We can give a
Thoracic plain block.
TTB block. We can give
What is it? What block?
bilateral TTB block, transthoracic plain block can be given.
How you will give?
So under ultrasound guidance, we have to give it in between the internal intercostal and innermost intercostal.
Okay.
We'll see a pleura dipping down
In the ultrasound guidance.
under ultrasound.
Okay, so any other block you will give? What are the
So
other?
we can give posterior blocks.
Paravertebral
ESB,
block or ESB.
Okay. So why can't you try any epidural or spinal in these patients for analgesia? Will it be possible?
Epidural catheter will be difficult because sir, we are going for a anticoagulation during CBB, sir. We are instituting high dose of heparin. So maintaining the epidural catheter and removal will be difficult. The chance of epidural hematoma.
So this is
Sing-
always risky. Central
risky
nerve
too.
always risky in these patients. You should never try. So now that a lot of advanced facial plane blocks has come, like transthoracic plane block and PAFP, pectointercostal facial plane blocks.
Yes, sir.
All those blocks has come and has produced good analgesia for the patients in the intraoperative period and reduce the amount of opioid consumption and all.
Yes.
So you can restrict the opioids to less than 5 mics or 5 to 6 mics per kg for throughout the surgery.
Yes.
So now most of the centers, they start giving facial plane blocks so that the patients have reduced opioid consumption and yearly postoperative recovery also good.
Yes.
Okay. Okay then.
And then we have to assess the transcatheter echography to confirm our findings, sir, and we'll see for LA clot. We have to confirm the finding to the surgeon.
Okay. Okay. So what are the things you will do in echo, transesophageal echo?
This is the menisophageal four chamber view showing dilated LA with the stenotic mitral valve with restricted opening. And there is a LA smoke also present because of the stasis. And color flow Doppler, we see that the same like before, flow turbulence is there, and a mild RA dilatation also we are able to see.
Okay, so the findings are almost similar to transthoracic echo, but it is little inverted image because it is a transesophageal echo
Yes, sir.
seeing from posterior,
Posteriorly, sir.
whereas transthoracic it will be seen anterior to the heart. The probe
Yes,
is
sir.
posterior, we are seeing from the anterior of the chest wall, anterior part of the chest wall. Okay. So here also the mitral valve is fully difficult to open. So diastolic doming is there, calcified, thickened, calcified at the tips and thickened, and flow turbulence is there. Correct?
Yes,
Yes,
sir.
sir.
Okay. And there is a smoke in the LA. That is because of stagnance of blood in the LA.
Yes, sir.
Okay.
And also in another view, we could see a clot in the LA with the filling defect when we appear a color flow Doppler.
Yeah, there is a clot in the left atrium, right?
Yes, sir.
Okay.
And same like we like that we apply continuous wave Doppler across the mitral valve to see the mitral flow, mitral inflow gradients, and pressure half time can be used to calculate the mitral valve area.
Okay.
So here we see that the pressure the mitral gradients are 13/8 only. Under anesthesia, there could be lesser gradients, and this is also another reason which we don't include the gradients in the classification of the mitral.
It's where it will come from, where the gradients will come from.
Because under anesthesia, the gradients will come down. It's
Yes, sir.
better you have to go by the valve area.
Always.
Yes, sir.
Okay.
And here we found a pressure uptime of around 388 milliseconds and giving a pressure mitral valve area of 0.6 centimeters square.
Okay.
Similar to as we found in transthoracic.
Okay.
And, additionally, here, since this patient is in AF, we should actually measure at least 5 cycles of this thing, an average then.
Okay.
Mm.
So how will you conduct the surgery? Like, what are the or how will you? I mean, so you're given anesthesia for the patient. So what is the next step? What are the monitoring you will do? Whether a patient need a cardiopulmonary bypass? What is cardiopulmonary bypass?
Yes. So,
Yes, sir. Actually, cardiopulmonary bypass. So we are taking a blood from RAR with SVC and ABC. We are putting a cannula. We are taking blood from right heart, and we are taking it to the blood reservoir. From that, it will go to the pumps. Might be the roller pump or centrifugal pump. In the bypass open circuit, it will maybe a roller pump. After that, it will go to the oxygenator. After that, it will here also ketone exchanger will be there. So temperature will be altered. After that, it will be returned to the patient's left side. So like aortic cannula will be returned. It's like it's a cardiopulmonary bypass. Sir.
Okay, so it's basically the function of the heart and the lungs are stopped, and it has been taken care of by the cardiopulmonary bypass machine. So the deoxygenated blood from the right side, that is from the SVC or IVC on the right atrium, is taken to the reservoir, and it is pushed by the use of pump. It is pushed into the oxygenator, where the blood deoxygenated blood is become oxygenated, which is the function of the lung, and it is given back to the oxygenator into the heart, where the pump functions like a heart, and the blood is circulated into the aorta to the all the organ systems of the body.
yes.
Okay, so this is the cardiopulmonary bypass. So we are going to keep them. Why you want to keep the patient in cardiopulmonary bypass for mitral valve surgery?
So we have to open the heart to assess to address the valves. So for the time we have to stop the heartbeat and for a surgery.
Okay. So also Yeah, also we need a bloodless
Bloodless
Blood with surgical field.
field, and also you have to maintain the organ protections like brain as well as the other visceral organs. So we have to use a cardiopulmonary bypass, which temporarily functions as a heart
heart
and
and the lungs.
for other organs. Yeah, heart and lungs for the other organ systems. Okay,
Yes.
so you use this. The surgeons will subject the patient to this cardiopulmonary bypass machine, and here they will do the surgery, right? So whether you can able to directly connect the cannula, or what you want to do, how to prepare the patient to shift the shift into the cardiopulmonary bypass, how will you prepare?
So it's like artificial circuit, sir. We have to anticoagulate the patient. We'll give a heparin dose of around 4 to 5 mg per kg, or 60 kg. We'll give 300 mg heparin and wait for 3 minutes. We'll take ACT, sir. And after
What is
that,
ACT?
so it's activated clotting time, sir.
Okay, so what
It's
is
indirect measurement. It's an indirect measurement of coagulation, sir. Even heparin is indirectly measured, sir. Ideally, we have to measure direct heparin, but it is not available. So indirectly, we are taking ACT as a measure.
okay?
So
Will
once
give
it crop,
estimation of the anticoagulation level, correct?
Yes.
yes,
Yes,
sir.
sir.
Why you want to anticoagulate the patient?
It's going to the artificial circuit, blood will got clotted, sir, and it will
It's an
get
external
embolized.
surface. It is not the
Yes.
blood. The blood is going into the external surface, the tubings. So that may cause blood clotting and all. So
Yes.
only you have to anticoagulate the patient with heparin, and you have to maintain the anticoagulation level by monitoring the activated clotting time.
Yes.
Yes, sir.
Okay.
So ACT level of more than 200, we can ask the surgeon to put a aortic cannula. It will be placed first.
Okay.
And sir, once ACT levels are reached to 200, I will take ACT after 3 minutes. Once ACT level is more than 200, the surgeon can place an aortic cannula, sir.
Okay.
You can go on bypass when the ACT is more than 480.
480, sir. Then venous cannula will be taken, and the patient will go for cardiopulmonary bypass.
Okay.
Before that, we have to, because we are stopping ventilation, we are not giving any inhalation anesthesia also. So we have to give a additional muscle relaxant and anesthetics in the pump also to
The
maintain the
cardiac-
anesthesia.
Yeah. Okay. So what are the things you will see before going on bypass, pre-bypass checklist?
Yes. So we have to confirm that we have given the anticoagulation and the desired level of anticoagulation is reached, that is ACT more than 480 seconds. And during arterial cannulation, that is aortic cannulation, we have to keep the blood pressure less than 90 to 100 systolic blood pressure, so that the cannulation does not result in dissection. And we have to ensure that there are no bubbles in the arterial line. And we should look for the aortic line pressures to rule out any dissection or malposition of the aortic cannula. And then venous cannulations are inserted. Superior venous cannula is inserted first, and then they go on partial bypass, and then they introduce a IVC cannula.
Okay.
And then
Pulmonary catheter, we have to pull back, sir, but now we are not pulmonary. And the echo is there, we have to keep in a freeze mode, otherwise it will get heated and it will cause a thermal
esophageal
injury.
injury.
Okay. Additional drugs should be given because patient is shifting from one system to the other, the cardiopulmonary bypass system, so that we have to give the drugs in the cardiopulmonary bypass circuit. We should not able to inject in the central venous line or anything.
Yes.
Okay. Then
If I head and neck to see the venous drainage, any congestion, the congestion will be there. Venous drainage will be
yeah, we should see a good venous drainage. The venous cannula should take good amount of blood, and the aortic cannula should be properly placed. If it is malpositioning of the cannulas, sometimes it may cause asymmetric blood flow and it may result in stroke. So that you have to watch for NIRS also.
NIRS, yes.
The brain blood flow is good, brain saturations on both sides is good or something like.
Yes.
Okay. Okay, then. So you are subjecting the patient to cardiopulmonary bypass. Everything is achieved. Then what you will do? Previous image.
like our CPB circuits.
So what are the things? Can you please a little bit show?
So from this is the patient, and from here we'll have the venous line coming, and it will come to the reservoir. This is the venous reservoir. From here, it is given to the pump. This is the CPB roller pump. From here, it is
oxygenator is kept here and down below the venous reservoir. After this venous reservoir to coming here to the pump, it will be pushed to the oxygenator and it will be given to the return cannula to the patient. Other pump will be used for a cardioplegia pump, and other two will be bench
Suction.
and suction pumps will be there. The main pump will be this main oral pump. After that, non-cardioplegia pump will be there. Other will be used for vent and suction.
Okay. So what is that cardioplegia pump? Okay, you're coming to that.
Yes.
Cardioplegia pump we are not there. Mainly venous.
Okay.
So cardioplegia is to basically to arrest the heart, sir. Potassium-rich solution more than 20 milligrams per ml we have to give to arrest the heart. So on sciatic class can be on. It will be a different type of cardioplegia, either bread and delino cardioplegia.
Where you will give the cardioplegia? Where you will give the cardioplegia?
Sir, after we go on bypass with aortic and venous cannula in situ, we'll clamp at the ascending aorta and
Please don't say.
this,
Yeah, sure.
yes, sir.
So what is this?
This is the
Yeah.
this is the ascending aortic cannula here. So proximal to it and near the heart, here we'll be applying a cross clamp, and proximal to it, we'll be putting a root cannula through which we can give a plegia to the heart.
So
That helps in,
potassium-rich solution, right?
yes, sir, potassium-rich solution.
What will be the potassium in that?
More than 20
20.
milligrams.
20 milliequivalent. So you are going directly into the coronaries.
Yes, sir.
So that will cost a
Diastolic arrest.
diastolic arrest of the heart.
Yes.
Okay. Okay. Okay then.
So once it is achieved, then once cardiac arrest is achieved with the flat line ECG and no activity in the heart, then surgeon can proceed with the surgical technique of mitral valve replacement, opening earlier.
Okay, this is a diseased mitral valve of the patient, right?
Yes, sir.
Okay, okay. Then what they will do?
Here, after resecting the diseased part of the mitral valve, they will take stay sutures around the mitral annulus, and they'll be placing a prosthetic mitral valve. Sir.
Okay.
So
what are the things you will monitor during these times, like till he places the valve, and what are the operative monitoring? I mean, during the cardiopulmonary bypass.
Anticoagulation should be maintained throughout, sir. And ACT level should be checked every 45 minutes. Sir.
Okay.
We'll see the ACT, and heparin will be repeated every 1.5 hours. Sir. Now, first dose given at 5 mg per kg. After that, we have to repeat 1 mg per kg.
That is to maintain the heparin levels.
Heparin
Yes,
levels.
sir.
Heparin will be metabolized, so you have to maintain the levels. You have to give 1 mg per kg based on ACT values, the activated clotting time values. Okay.
Yes, sir.
Then neuro monitoring.
And mean arterial pressure should be more than 50 to 60. More than 60 is better, sir. Even this pulsatile flow, non-pulsatile flow, we can't see the systolic and diastolic pressure. So mean pressure we can see around more than 60. We'll keep, sir.
Okay.
And so if it is less, we have to achieve with adequate pump flow, or we have to give a second constrictor to increase the SVR.
Okay.
And the NIRS should be monitored throughout, sir. If patient is having stroke, there is a reduction in cerebral perfusion might aggravate the stroke also. So we have to keep NIRS value less than 20% of baseline we have to address.
Okay.
So baseline NIRS we have taken, and the less than 20% reduction is there, we have to address NIRS, and we have to increase the
for
dose.
the position of the cannulas, any malperfusion is happening, or
Yes.
you have any embolic issues is happening.
Yes.
Okay. And you have to watch for the hemoglobin on pump.
Yes.
Yeah, hemoglobin flow we have to monitor, and CDD ABGs will take every half an hour, sir, to see how the patient is there.
Mixed venous saturation also. Venous saturation also you have to monitor on the cardiopulmonary bypass.
Yes, sir.
The organs are adequately perfused and
Perfused.
Glucose and lactate levels we'll see.
yeah, glucose. Or intraoperative target glucose levels, because these are cardiopulmonary bypass are more prone for the inflammatory stress response syndromes. So, what will be the more amount of the inflammatory markers?
We'll go with the liberal therapy from 110 to 180 we can accept. Sir. More than 180 we have to intervene with the chemotherapy insulin dose we have to give.
So how we will give insulin? On what basis?
So more than 180 blood sugar is there, then we'll give a 0.1 units per kg, around 5 units or 6 units we'll give. The dextrose we can give, otherwise we can give directly 2 units, 3 units we'll give, and we'll repeat the ABG within 20 minutes.
Okay. So will you start any infusions?
We can start the insulin infusion if sugars are constantly on the higher side.
So if it is not able to maintain the blood sugars with boluses of insulin, you can
Bolus.
start.
Yes, sir.
Only more than 250, then we have to start infusion.
Okay, then.
Mm.
So once the valve is placed, then what they will do?
Once the heart, when they're closing the heart, we'll be doing when we'll ventilate the heart and to
For
remove.
that rewarming, they will start. During the CPP, hypothermia will be initiated based on the duration of surgery. Mostly the patient, this vitral valve we will do with 32 degrees Celsius. It might be enough, sir. Moderate hypothermia is enough. So after that, surgeon will ask to rewarming during his last step. So rewarming will be started. That time we will give again we will give supplement anesthesia drugs like midazolam and other
muscle relaxant
will repeat, because rewarming again the drugs will get metabolized and patient might need anesthesia and muscle relaxation. And after that we will give a magnesium also will give during class clamp either. Once class clamp is open, there might be a reperfusion injury and there is chance of arrhythmias. The patient we can give amidon also we have to give, because sometimes the patient will go for AF, so can give lignocaine amidon also for this patient.
Okay.
So after that, we have to keep the things ready during the rewarming. Sir, we will prepare inotropes to keep ready. We'll plan to come off this patient with dobutamine radius. So I'll prepare and attach and keep in a center line, and I will keep my pacing box ready. Whenever the patient fixes a heart rate, it might be sinus or asinus rhythm that might need atrial or ventricular pacing. And the blood products also needs to be ordered and kept ready. Whatever I mostly many need of blood and the crave on any plasma therapy, we will order and keep. And
okay.
And so heart started.
Yeah, so you will maintain a normal temperature and additional dose of muscle relaxants you will give, and then you have to maintain a stable rhythm, and you have to see the start the inotropes and pacing wires. This is a temporary pacemaker, so you have to take the surgeons will give a temporary pacemaker wires for temporary issues with the rhythm, so that you can start the pacing of the heart, and you'll start the inotropes, right?
Yes, sir.
Okay, then you will start ventilating.
Yes, sir. Yes, sir. Once heartbeat is start and cross clamp is off, then we can start the ventilation, sir.
Okay.
So after that, then open heart surgery, then so air might be there, so we have to do a de-airing with the TE machine. We'll ensure no air is there in the left heart and left atrium.
Okay.
Left atrial appendage also. So then we have to make sure that the de-airing should be addressed with once heartbeat is started, we have to assess the de-airing with the TE machine.
Okay. Next
is like postoperatively. Then once we are planning to come up bypass, we'll assess the mitral in the post-op TE.
Okay, so what are the structures you can able to see here?
So this is a visual LV long axis view. Here we are seeing the dilated LV, LA, LV, and the prosthetic mitral valve. So the single leaflet mechanical valve. With colorful Doppler, we see that there is no residual MS, and there is two regurgitant jet coming, which are physiological washing jets. And the valve is normally seated, and adequate leaflet motion is there, and there is no paravalvular leak. Paravalvular leak we'll see in all the views to ensure that there is no paravalvular leak in any of the circumference.
What is paravalvular leak?
The jets which are seeing here are washing jets. If there is a jet beyond the valvular apparatus, then that is a paravalvular leak. That will be of higher velocity and can lead to hemolysis, and there will be hematuria.
Okay, so this is that jet which goes away from the valve ring.
Yes.
Sometimes the suture may not be properly stick to the valve. There may be some gap between the mitral valve annulus and the prosthetic mitral valve. So there may be some leak around it. So that is very detrimental for the patient. So if there is any leak, you have to see in the intraoperative echo, and you have to ask the surgeon to address it. Correct?
Yes, sir.
Okay.
Gradient
we'll also see for the prosthetic mitral valve gradient.
Okay.
Here we have a gradient of 9/3, which is
has become 3 from 22.
Yeah. Yes, sir.
Yes, sir.
From 22 to 3.
Valve is replaced. So
Excuse me, sir. There are quite a number of questions pending in the chat box. So
Okay.
can we go a bit faster, sir, so that we
Yeah,
can
in
proceed
another,
to the discussion,
in
sir?
another 5-10 minutes we will complete, ma'am.
Okay.
Yeah. So
So
rapid
following
questioning.
assessment.
Yeah.
Following assessment of the mitral valve, prosthetic mitral valve, and then we are satisfied with it, then we'll reverse the heparin effect with protamine. Protamine is given in the dose of around two-thirds of the initial dose.
So
Okay.
1:1
Or
upper
1:1. Up to 1:1 we can give, and we'll measure the ACT. ACT should have reached to baseline. It is less than 120. 100 to 120 is
blood transfusion if needed, sir.
Okay. So how will you manage this patient post-operatively? Short?
Yes.
Yeah.
so. After coming to the ICU, we'll monitor the heart rate, the invasive blood pressure, CVP, peripheral temperature, input-output monitoring, and serum lactates we'll measure serially. We'll also send for hemogram, coagulation profile, chest X-ray, and serial ABGs will be done for the perfusion.
Okay.
Yes.
What other monitoring you will do?
So, urine output will mainly input output this monitoring only will do.
Okay.
And it's like our ICU chart, most of the things will be comprehensively done, monitored in during initial post-operative days, very much essential. This dynamic, so we have to monitor the patient very carefully. If any surgical or medical bleeding is there, we have to address it, sir.
So how will you assess the bleeding?
Sir, it's if it is sudden drainage of more than 400 ml in the first hour, or more than 200 ml coming in 2 hours, or more than 100 ml per hour in consecutive 4 hours, it might be due to surgical bleeding, sir.
Immediately you have to
Otherwise,
re-explore the patient.
we have to take the
Sorry.
patient for
Yes.
re-exploration. That
Okay.
needs to be decided. Otherwise, bleeding is less than like 100 ml, that 10 ml, 15 ml, 20 ml per hour, but continuously coming, we can be due to the coagulopathy, the residual heparin apex platelet dysfunction also. So we'll see the coagulation results, and other things we'll reverse it, sir.
Okay.
We'll address it.
Okay.
Yes, sir.
Okay.
Most of ours, so then next will be some quiz questions only. If needed, we can skip also.
Yeah. So do you want to continue the quiz questions or you can skip?
So
What do
I
you
think you can skip with the quiz questions and go on to the chat box questions
Okay.
Yes.
We're done.
because
Yes,
we're
sir.
exceeding the time. Yeah.
Thank you.
Thank you. Thank you.
Thank you so much, sir. Thank you so much, Dr. Satish and Abhinaya. So now I'll be handing over the mic to Dr. Geetu to continue with the discussion part. There are many questions in the chat box also.
Yeah, please proceed fast with the questions. Dr.
Yes, sir,
Gitu?
there are a-
Yes.
Yes, sir. There are a few questions in the chat box. Someone has asked, can you kindly elaborate on the transvalvular mitral commissurotomy and closed mitral valvotomy? Are they both the same? And elaborate in short, what are they?
Percutaneous mitral balloon commissurotomy is a percutaneous procedure done in cath lab under TE and fluoroscopic guidance. That is more
Invasive.
it's
Minimally invasive.
minimally invasive as compared to a open heart surgery. And closed mitral valvotomy is a surgical procedure and it's a blind procedure. So if the valve is pliable, it's preferable to go for a percutaneous mitral balloon commissurotomy. And if it's non-pliable, it's better to go for a mitral valve replacement, not closed.
And the question is, what is the significance of grading MS murmur?
It will indirectly give a severity, but grading of murmur, it won't give a benefit.
Can this mitral valve disease patients, can they undergo exercise cardiac testing? Cardiac exercise testing.
Cardiac exercise testing is not done in symptomatic severe patients. In asymptomatic or progressive disease, like a stage B, in those patients, they can undergo exercise testing.
Yeah, in a stage B patient with the exercise intolerance also, that might be indication for doing a BPMC according to recent AHA 2020 guidelines. With the stage B, whenever exercise intolerance is there, then might come to the intervention that we can no need of go for a valve replacement. We can go with the PMBC. We can try. Valve is pliable.
Will they have to continue digoxin and furosemide on the day of surgery?
It depends. If the patient is not having a lot of pulmonary edema and electrolyte disturbances we are expecting, then we can avoid the furosemide on the morning of surgery. And digoxin, if the levels are well within therapeutic range, then it's okay to skip. Preferably given.
Someone has also asked how to treat AF in these patients.
AF already has been actually mostly will can achieve a rate control with the patient. Rhythm control won't be possible. So patient we have taken a beta blocker and ejection is taken. So already patient has achieved rate control of around 60. That will be achieved. So even AF with the control ventricular rate is good option. So even patient has sudden postoperatively, if the patient is having AF, patient according to the symptoms, the patient is having AF with the hemodynamic instability, then we need to go for a cardioversion acutely to treat. Otherwise, then we can go for a pharmacological management, like based on the routine guidelines.
These were the questions asked in the chat box. So we have discussed that.
Okay. So if you have finished answering all the questions, all the questions
Yes,
are
ma'am, all
over.
the questions from the chat box is over, ma'am.
Okay. Okay, thank you, Gitu.
Dr. Koshi sir is there? Yeah, I can see him now. So Koshi sir, you played very well today as a captain. Just gave the batting to the openers and the middle people. I think they presented very well with the full confidence. I was listening to the class and a very important topic, especially when you are going for the mitral valve replacement. I think in the coming years, this will be a more frequent surgery when we are going to have a real incidence being calculated in our country. So these type of cases, when are getting operated, they throw very challenges as discussed. And Dr. Sarvana Babu, he really outlined almost everything very precisely. And that's why the questions were not that many as we usually get in the class. So that means the class was almost self-explanatory. I think we still we have 2-3 minutes. And anybody wants to have a question, they can ask one or two. After that, we will be closing this class. People can raise their hands, then they can ask about the questions. They can unmute themselves and can ask. Or Kochi sir, your comments, please.
Yeah, this case was presented very well by Sadish and Abhinaya from my department, discussed extremely well by Sharavana. All aspects they are covered, including the guidelines, CPP management, how to assess the patient. And only one query I've got, I saw this echo is in sinus rhythm and the ECG is in AF. Any explanation, Sadish and Abhinay can give?
The transesophageal echo was the current patients who we were discussing. The transthoracic echo, this patients was not archived. So.
Okay. No, but also there is a possibility that the patient can switch between AF
Switch in the
AF and
sinus
sinus
rhythm.
rhythm.
AF and sinus rhythm. So you have the mostly you will come off bypass such patients in sinus rhythm, but they'll revert to
AF.
AF also.
AF in the ICU. So rate control is the most important thing as pointed out by Sadish or Abhinaya. But most patients with AF after MVR require a pacing in VVI. That's the only thing I have to make a comment. Otherwise, this was a very good presentation.
So I don't think so. People have many questions up now. At least it's time for ISA NHQ to felicitate our people who have done hard work today. So Dr. Thomas Koshi sir is the captain of the ship. So thank you, sir, for being taking this class also. It's a very important class and I think very useful for all the postgraduates as well as the people who have, I think, passed out also. They will be utilizing this class, with pearls of wisdom in the coming days and during the clinical practice. So thank you, sir, for being the leader of this class.
Thank you.
And Dr. Sarvana Babu, I think he has done a hard work in getting this class to this level and preparing the postgraduates in a very good manner. I think they presented very well. The hard work was reflecting in the class itself. So Dr. Sarvana, thank you very much for being the anchor of this class.
Thank you, sir. Thank you very much for giving the opportunity.
Yeah. And Dr. Abhinay as well as Dr. Satish. For Satish, we held this class for today because he was too supposed to go tomorrow. Anyway, thank you. You prepared very well.
Thank you,
And
sir.
I think when you are appearing for the finals, so you will be doing great job there also, as has
Thank
been
you, sir.
already endorsed by Dr. Sarvana in the beginning. So I think both of you, congratulations on presenting such a good class in front of the national audience.
Thanks.
And
Thank you.
Pratyasha, yourself
Thank
and
you, sir.
Purnima as
Thank you,
well as
sir.
Gitu, a very good tried team for the screen coordinators. So I'm
Thank you,
always
sir.
feeling good whenever national youngsters they come on the screen, they present themselves and their confidence grows, and that's how the young faculty is built in the country. So I think Pratisha and Purnima and Gitu they will be going forward, and with the class coordinators also, Dr. Madhuri, Dr. Nishan, Dr. Ritima, and Heli also coming now. So it's a good thing. So we are growing in this academics, and very soon we will be having some other stage of national international classes also. That's in the pipeline. I think in this coming year, it will be full of the international standards. We will be competing with other countries also, presenting on their platforms. Already signed few MOUs with the different associations. So, and we will be having classes. So these class screen coordinators will be coordinating on the national and international, the platforms. So that's how we will be going in the future. So anybody wants to say something else before we close this? No comments? So everybody satisfied and tired, I think, hungry, feeling hungry also for the dinner. That may be one reason. If we speak, it may get too long rather than just be silent and go for the dinner straight away. So I think that's all for the today. Thank you, Koshi sir, for being our chief guest today as a class captain. And hope to have more classes from your side, sir, in the coming days also. So we always end by saying, long live ISA.
Long live